you for joining us for accurate and timely MS diagnosis. This activity is supported by independent educational grants from EMD Serono, TG Therapeutics, and the Catherine C. Moore Foundation. Before we begin, I would like to bring to your attention the target audience and accreditation information. In addition, I would like to let you know that you will receive an email from education@mscare.org with instructions on how to claim credit for this activity. And I would like to let you know that the faculty reported the following financial relationships. And finally, it is my pleasure to introduce our moderator, Dr. Leora Freeman. Dr. Freeman is the medical director of the MS and Neuroimmunology Center and an assistant professor at the Dell Medical School at the University of Texas at Austin. And with that, it is my pleasure to turn the meeting over to Dr. Freeman.
Thank you so much, Laura, for the introduction. And I want to echo what you said. It's such a joy to be with everyone tonight. It's an important topic, and we're just going to jump right in. So joining me tonight is Dr. Mirela Avila, who's an associate professor of neurology at Texas Tech in Lubbock, Texas, and also Lindsay Hale, who is an assistant professor at UT Health San Antonio. Today, we're going to learn on the next slide how to incorporate the McDonald's diagnostic criteria into diagnosis strategies in evaluating patients with suspected MS in order to make more accurate and timely MS diagnosis. We can identify red flags to MS misdiagnosis in order to recognize and address them when evaluating patients. And we're going to be reviewing key imaging features to help with the differential diagnosis. I promise you a lot of beautiful MRIs to look at today. And with that, I would like to introduce Dr. Avila as she will present the first part of this webinar.
Thank you so much. It's a pleasure for me to be here, and I hope all of you enjoyed this presentation that we're going to give you. And first of all, let's acknowledge that MS now is a global disease. We can see how much it has the increment that we have throughout the years. And this last one is 2017. I'm sure that if we get a newer demographic, we're going to see that the prevalence of MS has actually increased significantly in the US and also worldwide. We know that it's more common in female patients with a 3-to-1 female to male ratio, and even that it's more common in places where we have more North European ancestry. We also see MS in patients in other ethnic groups, including Black, Hispanics, and Asians, and it tends to actually be more aggressive in Hispanic and in Blacks, and especially in male patients. Findings also suggest that Black women have a higher risk of developing MS than previously reported. So the problem is that we still can misdiagnose MS, or it can also be underdiagnosed. And what happens, as you know, is that we have good treatment options to prevent more lesions. But when there's a misdiagnosis or when it's underdiagnosed, the problem is that patients may accumulate disability, and we don't have a way to repair damage that already occurred. A recent meta-analysis actually showed that MS was misdiagnosed in about 15% of cases and underdiagnosed in about 36% of cases. Women tend to be more likely misdiagnosed. Migraine, cerebrovascular disease, psychiatric disorders are the ones that are commonly mistaken. I would add also that patients that present after the age of 50 may also lead to a misdiagnosis, because if you imagine if somebody is maybe 55 or 60% to the ER with a new neurological symptom, it may be thought that it's stroke before we think about MS. And the time delay to correct diagnosis have also been found to be extensive. And one study also showed that in the US, even in recent years, the mean time for the first symptom to diagnosis remains above 1 year to about 13.8 months. So why is it so important to recognize the presentation of MS? And here we want to talk about the typical MS symptoms and the atypical MS presentation. And the typical MS presentation will be somebody that presents with an acute unilateral optic neuritis. The patients can present also with some facial sensory loss, trigeminal neuralgia, usually patients that are younger than 40. But as I said, also think about MS if somebody is 50 or above. Cerebellar ataxia and nystagmus, partial myelopathy. Sensory symptoms can be pretty common too. Patients can present with internuclear ophthalmoplegia or a sixth nerve palsy. Lermite sign, which is the sign that of significant electrical pain when somebody bends their neck down. Asymmetric limb weakness, urinary urgency, incontinence, or sexual dysfunction. And a typical presentation would be like a red flag would be somebody that presents with bilateral optic neuritis or recurrent optic neuritis, somebody that had an optic neuritis with very poor visual recovery. That would be more suspicious of NMOSD. Somebody that presents with a complete gaze palsy or fluctuating ophthalmoparesis, somebody that presents with intractable nausea, vomiting, or hiccups. This speaks a little bit more about an ARS postrema syndrome with NMOSD, which stands for neuromyelitis optica spectrum disorder. Somebody that presents with a complete transverse myelopathy also. Somebody that presents with encephalopathy, a subacute cognitive decline, is not something that we commonly see as initial presentation with MS. Encephalopathy is not something that we commonly see with MS. Headache or meningismus, isolated fatigue or asthenia, or constitutional symptoms. So all of these will be considered a typical presentation of multiple sclerosis. So besides that, it's important to remember that there are some symptoms that we call invisible symptoms that the patient can be having. And it's important to know that these may be the reason why they're complaining and they're going to seek a medical attention. And as we're going to see in the next slides, the new proposed McDonald criteria 2024 includes that if somebody didn't have the typical presentation but have some symptoms and MRI findings, we may be able to make that diagnosis early. And that is really important to consider. Fatigue is really common. Up to 97% of patients may have the central type of fatigue. Bladder dysfunction also pretty common, between 52 to 97%. Sexual dysfunction, 40 to 90%. Pain between 29 and 86%. Spasticity also, especially with patients that have spinal cord lesions. Cognitive impairment between 40 to 70%. And also bowel dysfunction can be a reason why patients complain and seek medical attention. So the typical disease course of MS, we have the relapsing remitting multiple sclerosis. And in this one, we have the typical relapses, which are defined as a new neurological symptom that is constant for 24 hours. And then we may have some time in between, which would be months, sometimes even years. There's no way for us to predict when the next attack is going to occur. We also have the secondary progressive MS, in which after some years of having the relapsing forms, patients start having progression on top of some relapses, or even despite relapses, they start accumulating disability. The primary progressive MS, in which patients may have accumulation of disability from the beginning, which are these typical relapses, and the progressive relapsing, which is less frequent, in which a patient will have accumulation of disability on top of some relapses. But we also are grouping now MS as active and non-active MS. So you may start seeing more and more of us separating in general active and non-active MS. Over time, if you have been practicing neurology for a while, you may have seen how the MS criteria has evolved. And originally there was a criteria called the Poser criteria, in which it didn't include MRIs. And then the McDonald criteria came out, and it has had several revisions, 2005, 2010, the 2017, which is the one that we have been using until now. And why is this important? Is because it's getting easier and easier to diagnose MS earlier. And today we're going to be talking about the proposed 2024 McDonald criteria, in which, as we're going to see, includes some MRI findings, some biomarkers, and this allows us to make a diagnosis earlier. Why is this important? Because remember, we have a way to prevent, but we don't have a way to repair. So by being able to diagnose early, properly a patient, start them on a disease-modifying therapy, we are leading to less disability and improvement of the quality of life of our patients. So let's talk a little bit about the revision diagnostic criteria. And just here to illustrate and to remember our 2017 McDonald criteria, for example, if we have a patient that has 2 clinical attacks and objective evidence of at least 2 lesions in the MRI, we don't need any additional. But what happens if we have a patient that has 2 clinical attacks and an objective evidence of 1 lesion? Then we're going to need some additional evidence, and this can be a different site in the CNS or by MRI, or sometimes if they have 1 clinical attack, we may need more information, like for example, CSF-specific oleoclonal bands or other paraclinical testing. So let's talk a little bit about the 2024 proposed revision criteria. And something important to know is that now one of the differences is that typical symptoms are no longer required to make the diagnosis. Basically, the imaging is very heavy in the proposed revision. So the MRI findings that we're going to be talking about in more detail. And also something important is that patients that we used to call isolated that we used to call radiographic isolated syndrome could be now diagnosed with MS, and we're going to talk a little bit more about this. Also, the inclusion of the optic nerve as a separate topographic area. Remember, the other anatomical locations are the periventricular lesions, the cortical and juxtacortical, infratentorial, and spinal cord. So now they're adding the optic nerve as a number 5 anatomical location. The expanded use of biomarkers, the kappa-free light change, where we're going to be talking more in detail, as well as the MRI findings with the central vein sign and the paramagnetic rim lesions. So let's talk a little bit about the typical symptoms that are no longer required to make a diagnosis with MS and the typical locations of the MRI. So we know that periventricular lesions, as we can see here, are very typical. The cortical, juxtacortical to the infratentorial and spinal cord. But now we're going to be adding also the optic nerve as another site, number 5th site. But it's important to know that people with no clinical symptoms and with incidental MRI findings, which we used to call radiographic isolated syndrome, could now be diagnosed with multiple sclerosis. But this has to be very important to remember that this is under certain conditions, and we have to rule out other causes too. So the inclusion of the optic nerve as the new topographic, as I said, the number 5, the 5th anatomical location to demonstrate dissemination in space. So we know that the optic nerve is heavily myelinated. It is basically like a juicy steak, a target for the immune system. How can we help see how much the optic nerve is being involved? Visual bulb potentials can be very useful. We use this very common in my MS center. So if we have an asymmetry with the P100 peak time above the limit of normal, this can serve as evidence of optic nerve involvement, but you can also use optical coherence tomography or OCT that can serve as an evidence of optic nerve involvement. So the biomarker, one of the novel CSF biomarkers, is the kappa-free light chain. Kappa-free light chain is actually a protein produced by plasma cells. So it's a reflection of the B cell activity, and it is actually more sensitive than the IgG index. It is something that you can use as an alternative of oligoclonal band detection. And also it is, you can look it up in the CSF. It's actually, as I said, more specific than the IgG index, and this can be used as a biomarker now to diagnose MS. Let's talk a little bit about the MRI biomarkers that you may be starting to hear more and more. So the inclusion of these novel imaging features has been actually proposed to increase the specificity of the new MS diagnostic criteria, but also to help differentiate MS lesions from other etiologies. And we're going to talk about the central vein sign, and also we're going to be talking about the paramagnetic rim lesions, which you may be hearing about them as pearls. So we know that the central vein sign, the pathological hallmark of MS, is actually this perivenular inflammation and demyelination. Even in the 1800s, when Dr. Charcot gave the name of multiple sclerosis, he spoke about this association between lesions and blood vessels. But it was until we have this iron-sensitive scans with the MRIs that we can actually appreciate the central vein system sign. And it has actually a very high sensitivity between 95 to 97% and a specificity of 92 to 98%. So the presence of the central vein inside MS lesions is a well-established finding in histopathological study, and it can be very useful to diagnose especially MS and to differentiate it from other conditions that have white matter lesions, such as neuromyelitis optica spectrum disorder, chronic small vessel disease, migraines, or SUSAC. Also very important to remember is that it is present in MS and all the different MS clinical phenotypes, so relapsing remitting MS, secondary progressive, and also primary progressive. It is best seen with susceptibility weighted images, and even that is better seen with 7 Tesla and 3 Tesla, we can also see it in 1.5 Tesla, which is what most hospitals have available. But if you have a 3 Tesla, you're going to be able to see it with a better definition. And also very important that the presence of 6 of these central vein signs can be used as a positive lesion, can be used to support the diagnosis of MS, but is not required if you have enough criteria already that has been met. So what are the pearls or the paramagnetic rim lesions? So these are actually associated more to progression. It is iron. So we know that iron is actually a paramagnetic substances. Therefore, we can see it as a hypointense rim in the susceptibility weighted images. And these are actually talk about chronic inflammation. In particular, we know that there's the microglia and the CNS macrophages basically are accumulating this iron inside themselves. And these are in the chronic lesions, they are basically surrounding the lesions. So it looks like this little circle or ovoid shape, as you can see here in the picture, like a hypo-intense rim that you can see in the susceptibility images. These pearls are frequent in MS. About 50% of patients may have it. It is rare to see in other conditions, about 77% in other conditions. But the one that has been described, there was this case of 11 cases of patients that had SUSAC that actually had this. But it is believed that this was more an accumulation of the iron and not because of microglia like we see with the with MS. So the presence of at least one or more of these pearls can be actually used to support the diagnosis of MS, but again, is not required if enough criteria is already met. And I wanted to ask Dr. Freeman, since she was part of the North American Imaging and MS group, if she would like to speak a little bit more about this.
Yeah, no, thank you so much for kind of walking us through these new MRI findings. It's really fascinating. I think what I want to do is first acknowledge that it's intimidating when we bring new MRI features. Already recognizing the typical features of MS can be somewhat intimidating, and now we're bringing in these new signs. And I just want to reassure everyone that the community that has been a part of defining these new signs of MS is really going to come forward in helping bring the right sequence to clinical routine, helping the community kind of recognize these signs in clinical practice. So it's important to be aware of what those new criteria are highlighting. But we're going to do more work with you all, as these criteria change, also to familiarize everyone with how to see central vein signs of pearls, and then how to recognize them routinely. I wanted to kind of conclude with, like, how do we bring all of this in practice? Sometimes it's, we hear about these new criteria, but like, what does that mean in clinical practice? So let's kind of work through this. We have people that we see in the clinic, and they have sometimes this sign or symptoms of MS. Sometimes they come without symptoms, but most of the time they come with these signs or symptoms, and we think, oh, maybe there's something going on in the brain. And we take a good history. clinical examination. We usually order an MRI first. And, we have to ask ourselves very early on when we do the workup, are there anything that sounds kind of weird? Something that's atypical, either clinically, we can look at the MRI. Does the MRI look really typical for MS or not typical for MS? Because we have to remind ourselves that MS is a diagnosis of elimination. So, if there's anything that's really raised, a flag, we have to listen to our gut feeling and just explore further to rule out other mimics. But then if we have this, for, most common cases, we have a brain MRI and it shows some lesions. So how do we work through this from that point on? So we have those typical lesions. In some cases, we will have typical lesions in two areas. Let's say you did a brain MRI on one of your patients and they have some lesions that are juxtacortical, typical juxtacortical, and typical paraventricular lesions. So they have two CNS topographies. So then how do you work through that? And that's what we're going to talk about on the left-hand side. Well, then we might be able to see the central vein, in some of these 6 or more of these lesions, and that can help us come to the diagnosis. We may see lesions that are disseminated in time, some that enhance, some that don't enhance. So we have a past history in this patient of other events that can also lead to the diagnosis. Often, what we do frequently in MS and Neuroimmunology Center is that we're going to order the rest of MRIs of the rest of the neuroaxis. So we're going to look at, the spinal cord, we're going to look at the optic nerve. And if we find lesions that are in 4 of those 5 topography that we talked about, then and that all look typical, then we're going to be comfortable making that diagnosis. Now, if we don't have a lot of central veins, if we don't have a dissemination in time, if we don't have the 4 or 5 topographies, then we can order a spinal tap, look for the oligoclonal bands, or look for the kappa-free line chains to help with this diagnosis. So that's kind of, I would say about 90% of patients fall in that category. In about 10% of cases, we have people where, we just have one CNS topography. Even after you image the entire, neuraxis, you're kind of like, well, no, they just have, say, paraventricular lesions. So we can still come to a diagnosis of MS in that case, and that's what we see in the right-hand side. But we're going to need more arguments, and we have to be very careful in these cases when we don't have all the, different topography represented. So we're going to need at least either a CSF and central veins of pearls, or we're going to need that dissemination in time, radiologically or clinically with central vein sign of pearls. That's because, just having one CNS location, it's really hard to be very specific of MS in that case. So bringing in these novel biomarkers on MRI are going to help tighten that specificity for multiple sclerosis. I wanted to say a quick words about people who progress over time, because this is a new thing that they highlighted in the diagnostic criteria for 2024, is that, we've all seen sometimes some people that have a couple lesions in the spinal cord and they seem to progress over time. Often these patients were just diagnosed with transverse myelitis in the past. Now, if we have some more elements in addition to, even if we don't have lesions elsewhere, but we have a positive CSF, for example, we would be able to diagnose MS with just lesion in the spinal cord in those patients that progress over time. Next slide. So the key takeaways from this first part of the presentation is that MRI plays a central role here. And we need to be very familiar with what MS looks like on MRI, and that's going to be a part of our second part of our conversation. Remember that MS is a diagnosis of elimination. Remember that there are now 5 topographies, but that the specificity, in case of that we have just one topography in particular, the specificity for MS is going to be enhanced by the presence of a central vein sign or the presence of paramagnetic revelations. And with that, I'm going to hand it to Lindsay Hale, who's going to talk to us about the differential diagnosis of MS.
Thank you so much. So just to kind of go forward with our talk, I'd like to talk a little bit about the differential diagnosis of MS, because as mentioned before, this really is a diagnosis of elimination, and we need to be sure to rule out any other potential mimickers. So the most common mimickers for MS are autoimmune conditions such as NMO and MOG, Sjogren's, lupus, sarcoidosis, and vasculitis. Whereas some infectious causes such as Lyme, tuberculosis, and neurosyphilis can also mimic it, as well as CNS lymphoma. And then metabolically, vitamin deficiencies such as B12, E, or copper can present with similar findings in the spinal cord that can mimic MS. Next slide. So I want to highlight a little bit more about NMO and MOG because these are the most common things that you're going to see that can often look like MS. The main things to focus on, we'll talk a little bit about imaging differences here in a minute, but looking at the presentations where with NMO and MS, it's more common in females, whereas with MOG, you can see it in both males and females. With MOG, you're more likely to have an antecedent infection before symptom onset, where that's very rare with MS or other conditions. And with MOG, you're also going to have a relapsing presentation or a monophasic presentation. It's a 50-50, whereas MS and NMO both present with relapsing, and then MS uniquely will have progression as well. The main differences for optic neuritis, if you see bilateral optic neuritis, that's usually a red flag for MS. So you want to think of NMO or MOG. And if you see a longitudinally extensive transverse myelitis, you really want to think of NMO or MOG. Syndromes that are, a red flag for MS would be an area postrema syndrome or narcolepsy. Those are uniquely seen with NMO. And MOG can present with ADEM picture or encephalitis and with seizures. And then finally, really what to pay attention to is the risk for, or the rate of recovery. So with NMO, there's oftentimes poor recovery, whereas with MS and MOG, with each relapse, you tend to have a pretty good recovery. And then finally with MOG, you can also oftentimes have complete resolution of the lesions. So it is important to follow up on those MRIs and think of that if lesions are going away. So this is a little cartoon that shows where you might see some of these lesions. So the top row, I'm looking at FLAIR imaging. For NMO, you're likely going to see these in the fourth, near the fourth ventricle, in the corpus callosum, and then all the way to the right with enhancement, it can be periventricular enhancement. Whereas in the middle row with MOG presentation, these can be brainstem findings or cerebral findings, and they're often these large fluffy lesions with indistinct borders, and you can have some meningeal enhancement. Whereas MS in the bottom row, as discussed before, you have those classic topographies where you can have the infratentorial locations, the periventricular lesions where they go right up to the ventricle, the juxtacortical lesions that touch the cortex, and enhancement can be a solid enhancement or partial ring enhancement. So on the next slide, we'll be looking a little bit more at the MRIs themselves. So these are looking at FLAIR images on the first 4 columns, and then the last one is with contrast enhancement. So on the top row with aquaporin 4 NMO, you can see the different types of presentations with the brainstem lesions focusing around the fourth ventricle, and then extending into the corpus callosum, and then also all the way to the right, you can see these kind of enhancement, periventricular enhancement. In the middle row, you'll see typical presentations for MOG. These are the large fluffy lesions that can happen infratentorial or supratentorial. They often can have indistinct borders and large lesions, and can have the meningeal enhancement. And then in MS, just kind of looking at that bottom row, these are the typical locations that you're going to see. These are very discrete lesions that are very well demarcated and can be infratentorial in the brainstem or cerebellum. In panel M, you can see the juxtacortical lesion. And then panel N, you're going to see the periventricular lesions that go right up to the ventricle. And then finally in panel O, you can see the different types of enhancing patterns that may occur with MS, including the ring enhancing, partial ring enhancing, and solid enhancing lesions. Next slide. So to talk a little bit more about optic neuritis, because this can be a helpful distinction to rule out the different types of presentations, excuse me. So with NMO, it often presents with bilateral optic neuritis, and it's frequently going to involve the chiasm or posterior to the chiasm. With MOG, it's going to be more likely bilateral with anterior involvement of the optic nerve, and can have extend into peripapillitis as well. So you may have a little bit more involvement. With MOG, oftentimes clinically, you're going to see optic nerve edema because it will affect the anterior portion of the optic nerve. And then finally, with MS, you're going to have unilateral optic neuritis, and usually it's a short, discrete lesion. So when you look at the MRIs, you can see the different patterns, and hopefully that can help differentiate when you have a patient with optic neuritis between MS and some of the mimickers. And then on the next slide, we'll talk a little bit about the different presentations for spinal cord involvement. So looking at this cartoon, I think one of the important things to see is that there is a pretty big difference in how it can present with NMO, MOG, and MS. And these aren't just looking at the sagittal images, it's also very important to look at axial images because they can present very differently. So with NMO, you're often going to have the longitudinally extensive lesion. They're going to be bright and spotty lesions that can often be the same hyperintensity as spinal fluid. And you can have an elongated ring or patchy enhancement. Whereas with MOG, you can also have the longitudinally extensive lesion. It more often affects the central cord, and you get this characteristic H sign on the axial image. And also unique to MOG is that you're more likely to have conus involvement. So really looking at the end of the spinal cord to look for any involvement, that may help give you a clue that this might be a MOG presentation rather than MS. And then finally with MS, you're going to have these multiple short lesions, often involving the periphery, and they can be a ring or a nodular enhancement. So very different presentations, and you can really tell a lot between the different presentations just based on the MRIs and looking at both axial and sagittal images. So this just highlights a little bit more about what you might see on the actual imaging. So we're looking at the T2 sagittals, and then down below we're looking at the post-contrast, or sorry, the axial images. So in aquaporin 4 NMOSD, you're going to see those bright spotty lesions, longitudinally extensive. You can see that it's similar in intensity to the spinal fluid. Whereas with MOG, you may have these longitudinally extensive lesions that extend all the way down into the conus. And down below in panel F, you can see the characteristic H sign. And then with MS, you can have these short patchy lesions that are a little bit more discrete and may have partial ring enhancing pattern for enhancement as well. They're going to involve the periphery of the cord. Next slide. So to talk a little bit more about other potential mimickers, so Sjogren's is something that can look very similar to MS. As you can see on the MRIs on this top panel, you can have these discrete, well-demarcated lesions that oftentimes can look like MS or be in similar locations. It can present with myelitis, optic neuritis, or with cognitive symptoms. And one of the things to always think about with MS is just, evaluating for other systemic symptoms. Sometimes they may have some sicca symptoms, or looking for other rheumatologic symptoms that might help clue you in, because this can be very similar to MS in presentation. And also, it's very important to kind of look at the spinal cord as well, because you can have both central or peripheral involvement, and it can be a long segment or a short segment. So next up would be neurosarcoidosis. This is one that we often see in our clinics. So this can present with headaches, cranial neuropathies, or any kind of focal deficits. The MRIs can be patchy or a leptomeningeal enhancement. It's often diffuse, and you can have mass-like lesions or perivascular meningeal enhancement. The important thing when you think of sarcoidosis is also imaging the rest of the body, and specifically that CT chest to look for any mediastinal lymphadenopathy. Now on the next slide, we'll look a little bit more at the spinal cord. and look at how that can present. So with neurosarcoidosis, the most important key finding is that trident sign. So you can see that all the way to the right. And that is a key diagnostic feature for sarcoidosis and why it's so important to look at both axial and sagittal imaging, because it can often present in multiple different ways in the spinal cord. Next slide. So now to talk a little bit about CNS vasculitis, this can present with subacute headaches and cognitive changes, seizures, or focal neurologic symptoms. The MRI can show diffuse T2 hyperintensity or perivascular pattern of enhancement, and also present with multifocal areas of infarction. The angiography can be negative, especially when small vessels are involved. And so if this is within your differential, you may have to go ahead and do the parenchymal or meningeal biopsy to get the diagnosis. So something to consider if the presentation is a little bit atypical for MS. Next slide. Now, primary and intravascular CNS lymphoma can sometimes mimic MS. The first row, primary CNS lymphoma, this usually develops over weeks with headaches and seizures and neurologic symptoms. And in the right-hand side of the screen with the panels A, B, and C, you can see how this may present. It's typically a single lesion, most likely supratentorial, and oftentimes with homogeneous enhancement. So this one is usually a little bit more clear-cut. However, the bottom row, intravascular lymphoma, this is where you have malignant B-cell tumor cells that actually invade into the brain cells. And so this can present with similar symptoms and also similar MRI findings with diffuse white matter changes and subacute headaches, cognitive changes. So as you can see in the pictures to the bottom left, you can see the patchy ischemic lesions on DWI and diffuse white matter lesions. Next slide. Just real quick as far as infectious causes, Lyme disease can sometimes mimic MS. It's usually brainstem involvement. And then metabolic, so if you have a spinal cord lesion and it's primarily involving the dorsal column, you want to think of vitamin deficiency. So be sure to rule out B12, vitamin E, and copper deficiencies. So in conclusion, just looking for red flags. So if you have a patient that is over 50 years old, be careful and really just rule out any other potential cause because that could be a red flag. If a patient comes in with bilateral optic neuritis, that's a red flag for MS, and especially if they have poor visual recovery. I would think more of NMO if a patient does not recover quickly with steroids. If they have leptomeningeal enhancement or encephalopathy, those are very unusual for MS. If somebody presents with area postrema symptoms, so the intractable nausea, the vomiting, the hiccups, that's also important to think of NMO. And of course, always screening for any kind of systemic symptoms. Do they have a headache, meningismus, narcolepsy, joint pain, weight loss, fevers, rashes? All of those could point to another autoimmune condition. If there is persistent enhancement for more than 6 months, that's very unusual for MS. Or if the lesions completely disappear, also unusual for MS. If the spinal cord involvement is longitudinally extensive, or if you see any atypical CSF finding, it's really important just to broaden your differential and really make sure that you're ruling everything out before you come to that conclusion of multiple sclerosis. So now I'll turn it over to Leora and on to questions.
Yeah, no, and for this, I would love to thank you very much. I mean, I think it's a lot to take on, just so many beautiful images, and I love that folks are going to be able to look back at this presentation. And I welcome Kathy Costello, the interim president of the CMSC, with us to kind of, just bring on some questions. I'm turning it on to you, Kathy.
Thank you very much, and thank you all for your presentations. They were, in fact, excellent, as I expected they would be. There are a few questions, and the first that I have is, what do you believe, and this can be to Mirla, what do you believe the drivers are for the now higher incidence that we're seeing in Black women? Is it better diagnosis, or is there actually something that you think might be driving that environmentally, for example?
I think it may be a combination of better diagnosis, of better knowledge about multiple sclerosis in general. But I have to say, we did publish in 2020 with our group increased number of cases with COVID. And what I believe that happened during COVID pandemic was that there was this burst of your immune system because of COVID. And if you had a tendency to develop autoimmune disorders, then it was a perfect storm. So, and this was not seen only with MS, it was seen with many other autoimmune disorders. So it could be a combination of both, but definitely we're recognizing MS much more than what it used to be.
Yeah, for sure. Thank you. When you presented the slide, the graphic that we've all seen, relapsing and secondary progressive and primary progressive, that is traditionally how we've always looked at MS, but I'm wondering your thoughts, and certainly anybody can chime in here, your thoughts on changing that view to kind of one disease that has more inflammation early, and then as people age, more progressive changes. So I'm seeing nodding heads, but I'd just love to
I can take,
hear your thoughts.
I'm happy to take this one.
Okay.
I often tell, I know our patients are, there's this stigma about progression, and, people are afraid to be told they have progressive disease. It's a hard diagnosis. And I like to explain to my patients that, for me, MS is a continuum progression. The mechanisms that lead to progression start at disease onset. So really, we're talking about one disease that is going to present differently across the lifespan and based on different mechanisms that occur, at different points in time. Early in the disease, particularly when the disease is diagnosed in younger adults, we are going to see these patterns of inflammatory, lesions that are due to this peripheral inflammation, immune cells that get activated in the periphery, get into the brain through the blood-brain barrier, causing these new active lesions, causing relapses. As people age, we know that past the age of, 50, we start seeing less and less relapses. And what we see is some patterns of inflammation that differ. We start seeing, macroglial activation, the slow expansion of lesion due to this, this edge that Mirla talked about, these macroglial edge to these chronic active lesions that are seen on MRI as the paramagnetic rim. And we see these new profile of the disease that express itself as progression. So we have a change in the pathology, but we have probably some patients that will have early on some indicators that they may be more likely to have progression later on. I think that's the next stage for us, is thinking, MS is not like you turn a switch and all of a sudden you're progressive. It's something that really settles slowly, likely from very early in the disease course. Now, the next phase for us is to understand and to try to stratify our patients to know which one are at risk for progression and which one may not be.
Yeah, this is a follow-on question. It's a little outside of what we were talking about tonight, but do you think that in kids, for example, they're not known to be progressive, they're always relapsing with MS? And so do you think that that's just because of that earlier presentation, and the younger you are with MS, it's just going to present with more peripheral inflammation?
Yeah, we know that a lot of the risk for progression is age related, and a lot of the pathways are aggravated, by aging, the aging of the immune system, the aging of the brain. All of this tends to drive, the biology towards a more progressive biology. So it's not surprising in this context that children will have more of this active immune system in the periphery that drives a relapsing presentation and phenotype. But that doesn't mean that these kids never progress. Ultimately they become adults, and with that, the disease and the pathology changes.
Thank you. Thank you. Let me see here. So, this is around central vein sign. And so, and it was mentioned that this is not widely available, but what are your thoughts on, this is a pretty important sign that can really change this diagnosis from a clinical diagnosis to really one where we're using MRI as the main driver. So what are your thoughts on the availability, or this becoming available and when that might happen for people who are in clinical practice in the communities, for example.
It's not as difficult as we think to have it available, actually. With the susceptibility weighted images, that it doesn't take much for us to ask our radiologists to make sure. Most of the time they do add it in the MRI. It's more getting used to seeing it and looking for it. And
Okay.
see it in the 3 Tesla and also in the 1.5 Tesla. Now, if your center has an open air, that way be difficult to see. But if you have a 1.5, you could be able to see it with that SWI. And it's not a lot of cost added. It is actually something that we use more for look at blood and stroke type of thing. But it is something that we have accessible at not extra cost in most places. I don't know if you add anything, and Dr. Freeman.
Yeah, I would love to just add something. I agree with Mirla. SWI can be added to protocols and are generally recommended. What's tough with the SWI is that sometimes we don't quite see well the lesions behind, the veins. So we may be able to see the vein, but it's hard to see the lesions unless we superimpose images sometimes. There's a lot of the work that has been done in research uses a flare star sequence, which is right now just a research type of sequence. And those images, like for instance, what we see in the presentation, use flare star, and are really beautiful because they integrate, kind of the visibility of the lesion with the visibility of the central vein. There's a lot of work being done by the North American Imaging and MS Cooperative and the people who are driving, the central vein sign worldwide to try to make the best sequence available routinely. So I think this is going to be a work in progress. We have to get used, we have to familiarize ourselves, start with what we have, susceptibility weighted imaging, for example, but also recognizing that as this becomes now part of the criteria, there's really going to be this incentive to bring these better sequences to the forefront. I have a question for my presenters today. And, Lindsay, we talked about differential diagnosis. And sometimes, thinking about the differential diagnosis starts with the conversation we have with our patients. Do you have some questions that you always ask patients, to try to help tease out whether it's typical or atypical? What's your process?
So just in approaching a patient, I really let them talk and tell their story first, because oftentimes they're going to give you a lot of detail and you'll get a lot of answers from before you even start asking questions. But I'm always asking about all the different possible symptoms that could happen with MS or any other autoimmune or neurologic condition, CNS condition. So really trying to get a good history as far as timeline, symptoms, was there recovery, what else was going on? Is there anything else that it could be mimicking? So, if they're having some pain in their eye, are they also having vision impairment, color changes, other things along the lines to really point me in the right direction? But ultimately just going through my review systems and working through every single system and asking those questions are really important.
Yeah, I find it's always important asking, questions about like general symptoms like fever,
Yeah,
other things that reflect more systemic conditions. I find that this can be really helpful. Weight loss,
yeah.
cognitive, but abnormally, kind of more encephalopathic kind of symptoms. Confusion is a question that, we really want to really understand as well. So, it's important to be thorough again. Thank you for highlighting that.
And this is a nice segue to the next question, because the question is that sometimes the symptoms in the MRI are not quite as clear as those beautiful images that you presented. And it's a dilemma. And so you've kind of talked a little bit about this, about asking questions and so forth. But if you're at that impasse where it's just not clear, the question is, what are your next steps? Like, how do you navigate through that unclear, like you're not thinking it's MS, but it could be, but maybe it's NMOSD, but it's not perfect. So how do you work through that?
If I could answer this one, well, NMOSD, you can rule it out with the testing, with the antibodies, aquaporin 4 antibodies. But also very important to remember that there are other things that can add evidence. So we were talking about the optic nerve, so visual bulb potential, OCT, that can help you add evidence. With the spinal tap, in which you can look for the kappa light chains, oligoclonal bands, this can also help you. But at the end of the day, the history, a good physical exam, and MRI are very important. So once you rule out everything, if you're still in doubt and you don't find more evidence with the visual potential or CSF, I would say keep that patient very closely, redo another MRI, and try to look for that dissemination in time and space.
Yeah,
Yeah.
I
How
love
long would
this.
you wait for that MRI? I'm sorry.
No, I was gonna say, I love this. Time sometimes is the answer. You know?
Yeah,
Right.
and as it can be very frustrating for a patient. I completely understand you want to have answers, and it's nerve-wracking thinking that you may have something and you don't know exactly what it is. So usually it depends on the situation. If I have a high suspicion, I may not wait much over than 3 months, but sometimes you wait 6 months. Um, but I don't know if anybody else has a different opinion, but
Yeah, no, usually it's that range. I think it might depend also on the patient, and the severity of the presentation and in some patients we may suspect something else entirely, sometimes even something neoplastic, and we want to really assess the growth. I have some folks where something neoplastic was on the differential where we repeated MRI at 1 month, because we really wanted to see, like for instance, we may have treated with steroids, we were unsure, and we're like, time is going to give us the answer. So I would say 3 months is a good rule of thumb. But depending on the presentation, it might be a bit sooner or a bit later.
Yeah. You mentioned steroids. So depending on that presentation and your concern that this is clearly something inflammatory, even if you weren't able to pin down that diagnosis, would you be willing then to give someone steroids based on symptomatology?
Personally, again, it depends case by case. There are some cases where, depending on the differential, we might do that. There are some patients where we're like, the differential is really scary. We might go and do a brain biopsy, before we give steroids, right? So we have to really assess case by case. But there's some situation where sometimes giving steroids and assessing response can be a part of the diagnosis workup. If the person doesn't respond at all to any steroids or any other kind of immune treatment, that might be a part of the answer. Again, it's a very individualized process,
Yeah, for sure. Thank you. Do we anticipate a publication on these beautiful criteria anytime soon?
Crickets. We don't know. I'm sure it is going to come. But I think it represents really a leap, when we look at the criteria over time. And I love what Mirla walked us through, right? When you think of the exposures criteria, no MRI, I mean, it's so foreign to me. And then we now we have not just MRI, but all these novel signs. I think this revision is a little bit of a leap compared to the prior ones, just because of the very, imaging and biomarker centricity of the criteria. So I think that there's a lot of things in, how this is going to be published and explained that needs to be worked through. So, but
yeah,
I'm sure it's going to happen.
One last question with the biomarkers, particularly the kappa-free light chain, which seems to be an improvement over oligoclonal bands, both in process and in outcome. Are you experiencing any difficulties with insurance in getting that covered as part of your panel for your CSF?
I think this may vary where you practice. So we were talking about this a little bit before. I have personally, but I think Dr. Freeman was saying that she has. And so I think it depends on the payer mix, where you practice and all that. But I'm thinking now with all this evidence, we're going to see less and less issues with coverage. I think eventually we're going to be able to say, this is something important, this is something that we can cover, hopefully.
Yeah.
Agree.
Especially when we have that publication.
Right. That'll help a lot for sure. Yeah. Well, that ends the questions that I have had. And so I want to thank you all for your great presentations and this great conversation as well. So I'll turn it back to you, Leora, for final comments.
Yeah, no, I mean, for me, I think it's really interesting to see the field evolve, to see how, we are, not only are we able, with each revision of those criteria, able to diagnose MS earlier. Now, these criteria really introduce also some signs to increase the specificity Because I want to say sometimes it's not just a problem of underdiagnosis. It's a problem of misdiagnosis, people who are given a diagnosis of MS, but don't have MS. And that is also a problem because these people end up being on disease modifying therapy that they don't need. So we really want to be able to diagnose people in a timely manner, in an accurate manner, so that we have a proper use of our highly effective therapy. So I feel like, we're really moving in the right direction with these novel biomarkers that add specificity. I find that, for our colleagues who are listening to this, what's really important is, go back and review these slides. I mean, I love how Lindsay walked us through these MRIs and these different presentation. I find that for myself now, it's not just recognizing a typical symptom from atypical. It's really looking at the MRI, looking at it precisely, looking at different, orientation, looking at sagittal and axial, looking at things differently. That's really going to matter. So I think really being able to just become very proficient with imaging is important. And I want to say that, it's important for those of, that are listening that may not be at an MS center, maybe, in the community as neurologists, and doing a fantastic job just getting people through the doors and, seeing them and getting them to a diagnosis, knowing that, they can reach out, to others in the community that are, MS specialists. I know that, I have colleagues from the community that have me on speed dial because we're here to help. And sometimes, sending us a quick snapshot of a, picture of a patient can really make a difference. So building those relationships in your community is really important. So take the time to do that and, be in touch with us if you need us.
Well, I want to thank you all for joining us this evening. And I also want to send out a huge thank you to our esteemed panel. Thank you so much for being here tonight. I would like to let you know that we would love you to connect with Can Do MS. To connect with us, you can follow us on social media for the latest programs, resources, and MS news. I would like to remind you that this is a 3-part webinar series. The second part of this series will be next Wednesday, 4/23, same time. We're going to be talking about DMTs for MS, initiation, monitoring, and rationale for treatment change. And again, thank you for joining us. We appreciate you being here, and thank you again to our esteemed panel.
Thank you all.
Good night.